Hey team, Sean Haverson here, back for our second installment on the central nervous system, where we'll be reviewing the structures of the overall brain. Now, you really can't know too much about the brain. In fact, it's not even been touched on as far as scientific research. There's so much about the brain and what the connection is between structure and function that is still in study and will be probably for many decades to come. So, as a paramedic, we want to narrow down what you really need to focus on. So we're going to talk about the overall large structures and regions within the brain. We'll identify them visually, so you can do so for an examination and on your homework. And we'll also work on describing their functions. I'll try to relate this to your current practice and future practice as a paramedic as I make my way through. So for that reason, some of my explanations will be a little bit long-winded. Now, we can explore this in total. We're going to look at the brain through guided assignment in the Complete Anatomy app. So we're going to start with actually the meninges, which is the next slide from this. So I'll go to that as soon as I describe it so that we can all get kind of a feel. And I'll try and do that as I make my way through. If you don't want to look at it and hear my description, you certainly can do so on your own in the app or use the book or some other resource, whatever it is that you choose. But those will be optional slides for us. So let's get started with the meninges. The meninges are a set of layers that are protecting the brain, and they're separating the outer region of the brain and actual neuron structure and the inside of the cranial wall, so the inside of the skull. Now, this shouldn't be new to you, and as we're thinking about this, well, let's go straight to why we need to know this. We need to identify which type of structural phenomenon occurs in each of these regions because they are going to be associated with signs and symptoms. And those signs and symptoms we absolutely could have in a even small level amount, theoretically small amount of trauma to the skull. So think back to the medical conditions or really traumatic injuries of epidural bleeds, epidural hematoma, and subdural hematomas. Now, those are two of the few different types of brain injuries that our patients can experience, but they're describing regions around these structures. So let's talk about the structures themselves, what makes up the components of them, their function, and then that will give rise to the signs and symptoms of epidural and subdural hematomas. If you don't remember, you may want to just look it up so that you're on the same page as to make my way through and pause the video. Don't worry, I'm not going to go anywhere. Okay, we're in the Complete Anatomy app now, and I've selected the next in line from our last set of lectures on the central nervous system, the next lesson in Complete Anatomy that we've paired with it. So for everybody's sake, whether you have Complete Anatomy or not, I'm going to try and cover these with a little bit of visualization as we can, make it a little bit interesting for us. Okay, so in the meninges and the blood vessels section, you're going to be able to explore some guided structures and terminology associated with them in the Complete Anatomy app. So what I've done is I've removed all of the brain structures in a dissection, if you will. And this is not the skull. This is actually the meninges, the layers that we're talking about in lecture for this slide here. And I've done so because it's important to memorize when learning about the meninges where blood vessels are located in relation to them. And that's important because there's different qualities of the bleeds that happen there, and that will give us different signs and symptoms. So let's connect some dots. There's also some videos on the app if you'd like to watch specifically of these bleeds. Okay, so I'm going to kind of turn here and show you that these would be blood vessels on the outside of the skull, and this blood vessel is actually on the inside of the skull but on top of the meninges. So epidural means outside of the dura mater, and the dura mater sits between the skull and the arachnoid space. So in that space, the epidural space outside of the dura mater, we would say that the qualities of vessels there are kind of unique to the other areas because this is where arteries are. Now, arteries commonly follow bone throughout the body, and usually this is a really good thing. If you think about where your femoral artery is anchored, it's pretty deep in the thigh and not superficial, so a small gash in the thigh doesn't cause the person to bleed to death. But this case here, our brains aren't going to have the same protection as the rest of our body would, otherwise we would be blockheads, like probably literally. So what's occurring here is we have grooves on the inside of the skull. Now, when you're in the classroom, even if it's for lab, grab one of the skulls from the skeleton mannequins, take off its cap. Please make sure it gets back afterwards, but take off its cap and look inside, and you can see the actual grooves where arteries are on the inside of the skull. That's anatomically correct. So if there's arteries in this space, then if there's a bleed, we can expect what qualities compared to veins. Right, so an artery bleeds faster than veins and with more pressure, so bleeds here accumulate pretty quickly, unfortunately, compared to the subdural bleed. The downside is that you're probably more likely to have an epidural bleed than you are a subdural bleed, because we pass by the arteries to get to the veins that are in the subdural space. And I just gave that piece away. So the veins are actually sitting in the space between the pia mater, which is shrink wrap on the brain, and the dura mater. And in that area, there's a cobweb of tissue that's connecting in a spider web presentation. And that's where our cerebral spinal fluid circulates. It's also where we have a lot of veins. So the veins are going to help us with drainage, equalizing pressure, and cerebral spinal fluid's a good means of cushioning the brain with fluid from all sorts of basic trauma, but probably not effective for the mechanisms we see. And then it's also nutrient rich as well. So if we have a subdural bleed, meaning it's meaning it's deeper to the brain than the dura mater is. So it's between the pia mater, shrink wrap on the brain, and the bottom side or the inside of the dura mater, so the arachnoid space. So that's a subdural bleed, and since it's veins, they bleed a little bit more slowly over time, and their signs and symptoms will, because of that, come on more slowly. Signs and symptoms compared to the epidural bleed. Our epidural bleed usually has some presentations of symptoms associated with the phenomenon we call walking, talking, dead, in which the person will have an head injury. They'll briefly lose consciousness from the force of trauma, and they'll regain consciousness perhaps while you're on your way or when you get there. And so you could be interviewing this person and think they're totally fine if you're not looking at the mechanism of injury, and then as soon as you get that person to stand up and walk out of your rig, they collapse, fall unconscious, and generally die very quickly from that. So it could be that assigned refusal is administered on a patient that has an epidural bleed unknown to us if we're not investigating and remembering this anatomy appropriately. So as you look through here, look at the meninges in the brain. You can see the blood vessels are kind of left in place inside the cranium. These yellow structures or gold structures here are nerves. And went a little too crazy here, but I'm zooming in on the spinal cord. Although this is a central nervous system brain section, I left the spinal cord in place because the meninges are contiguous with the brain. So around the spinal cord, we have the same level layers of meninges. Cerebral spinal fluid will directly circulate through the spine from the brain. And when a person receives an injection like an epidural, they're receiving the anesthetizing medication into that space. So that's where the nerve block is associated with for cases where lower extremities maybe have to be operated on, and it's commonly known from its use in delivery. So what I'm indicating here, though, is not actually that injection. This little blinking red light, this is indicating pain on this app. So I've put this target here so that you can look at it, and it reminds you of nuchal rigidity. So nuchal rigidity is a phenomenon in meningitis, also applicable here. Not necessarily trauma-based, but meningitis is inflammation of the meninges, as the name suggests, and that inflammation tends to go not just in the brain. Meningitis often we think of as having a headache associated with it. They can also have backache and nuchal rigidity, and that's because of the swelling that's occurring right here, literally in the neck. So it's a pain in the neck, as it's described. Okay, we'll get back to the slides now. Okay, so moving on to another important structure in the brain. We're going to discuss the brainstem. Also has a section in Complete Anatomy, and there's also a couple of videos that you might be able to find in the Complete Anatomy app once you have access. The brainstem has three major sections in it. And the three major sections of the brainstem have very important roles because the brainstem is our root of connection between the brain, so it's at the stem of the brain, and our neurons now merging into the spinal column to move on as our actual spinal cord. So the three sections of the brainstem are important to us because of illness and injury in this region, and their importance will give rise to signs and symptoms that we could connect to illnesses as well. Remember something, that when we talked about white and gray matter in the previous lecture, white matter is identifying a specific type of brain structure. So think back, what did I say about it? White matter versus gray matter. So white matter will have what in it that is not present in gray matter? Okay, good. The white matter is going to have myelinated sheaths associated with axons. So you're looking at actually the nerve conducting axon of a neuron. And then the gray matter is a mix of axons that don't have myelination on them and the other structures like dendrites, the soma of the neuron, and all of our glial tissue as well. And so that extends actually down into the spinal cord. So those tracks are going to make their way through the spinal cord, through the brainstem, into the brain for both our sensory and motor tracks. And let's just practice those terms again. Sensory is our pathway going towards the brain, if bad English, going at the brain, so they are our afferent pathways, and motor tracks are going to have an effect on some organ. They go away from the brain, and so they're going to be efferent versus afferent. Excellent. Let's move on. So this picture of the brainstem just kind of quickly highlights the regions, and we can also identify a few other structures here. So as mentioned, we've got some blood vessels circulating through, and here we have our basilar and vertebral arteries going along the medulla, through the pons, and extending past the midbrain, and then going basically wrapping around through our cerebrum. So the midbrain in red is connected at the base of it to the basal ganglia, which we'll discuss in a second, and that's a collection of things that are connecting the cerebral cortex, the thinking, the motor control, the voluntary control of our body, to the brainstem, where those motor neurons make their way out to the body to have their effect. Now, sitting behind the pons and partly connected to the medulla and the midbrain is also our cerebellum. The cerebellum is a part of our brain that is essentially extremely important. It's a very small piece of our brain, but has a big role in making sure that we can have more than just gross, meaning kind of blocky, not very coordinated, to fine motor skills. So fine motor skills are very coordinated. In fact, in our job, starting an IV without the work of the cerebellum is going to be difficult. So the cerebellum is helping to modify the signals that are sent in the efferent pathway from our higher level of the brain, the cortex, and that all goes basically through the brainstem to get to the spinal cord. And so the cerebellum is modulating those movements so that they become fine and coordinated. And some of that actually takes practice over time for us to build. So let's talk about the three levels or the three sections of the brainstem. The highest level at the center of the brain, given its name, is the midbrain. So it's in the middle of the brain, right at the center, as if this was like a multi-layered an onion. Sometimes it's described with multiple layers built upon one small center layer. Well, that would probably be the midbrain and the basal ganglia. So this is connected to the upper region of the cortex, as mentioned before, to the hypothalamus and the thalamus, the basal ganglia, and then moves its way down to next in line, the pons. It also has a connection to the motor centers that are in the cerebellum, as described as our fine motor skill center. So the midbrain is going to have control over things like vision. It's going to help coordinate hearing, especially since it's a little bit within the region of communicating from the ears to the temporal region of the brain. Motor control, as mentioned, to make it its way into the spinal cord, so it actually becomes more than a thought, but an actual motor control. Very important in sleep-wake cycle and temperature regulation. And since it's located right essentially in line with the hypothalamus, that should make sense given the role of the hypothalamus in temperature regulation. The basal ganglia is a region that sits on top of the midbrain, sometimes called something along the lines of a forebrain, and it's going to connect the outer regions of the brain called the neocortex, the cortex, or the cerebrum. There's lots of different terms for it. That basically mean it's the newer region, it's the outermost region of our brain. That's where conscious thought and our motor control can originate from, especially voluntary motor control, like purposely doing something like walking across the room. You probably know that the left and right brain are kind of divided for the most part of their brain centers, but we do have a crossover of motor controls, the left brain connecting to the right side of the body and the right brain connecting to the left side of the body. That happens at the basal ganglia and the corpus callosum with it. Let me pause here and let's highlight some stuff that's going to help you remember this and apply it. Okay, so vision should make sense because the optic nerve is going to be passing through it to get to the occipital region of the brain. Now, hearing, as mentioned, it's going to coordinate with the outermost portion of the brain. Motor control, that's the entrance to the spinal cord. So all that stuff makes sense, right? So the motor control, the hearing, the vision changes that can happen with patients that are suffering injuries or strokes in this region can be telling of what's going on. So if we have a patient that's suffering a traumatic brain injury and blood is accumulating, like in our previously described epidural hematoma, that's going to eventually push down on the brain. And when it pushes on the brain, the only place that the brain can exit is out of the base of the skull at the foramen magnum. The foramen magnum is where the skull is surrounding and the brainstem extends into the vertebral column. So if all the pressure starts on the outermost part of their body, of their brain, and then moves inward, it's going to start applying most of its pressure at the point at the center of their brain. That's the brainstem and the midbrain. So we notice that when patients have head injuries, especially with increasing intracranial pressure, their sleep-wake cycle is disturbed and they'll end up losing consciousness fairly easily. They'll have motor control off to a degree where it may be slurred, it might be sloppy, it might not be present to a side of their body perhaps. Vision changes as well could be an early sign that they have, maybe even before we get to the scene after the injury. The dopamine production with the motor centers is an important neurotransmitter in the process. And remember that when we have our motor control centers associated with an injury that we talked about in the last section, Parkinson's, we end up with these tremors. And remember, we can't get dopamine across the blood-brain barrier, so we can't just give it to them because that's what they're low in. You can see now where it's connected to the motor center and those signs and symptoms. So we've identified what happens in a herniating head injury, and we've also talked about changes when the person's experiencing Parkinson's. So there's the connection we need to make for our practice in the field. Going deeper, or I should say probably leaving the brain and moving towards the brainstem, is now the pons. So the pons is below the midbrain, and it's essentially in the middle of the three. It's the middle of the three structures. Squeezed between the midbrain and below it, the pons. Below the pons is the medulla oblongata. The pons is really important in the beginning of some of our vital centers. The midbrain wasn't as important to some of those things, but we'll find that the pons and the medulla are essential in our what we call vegetative structures, our ability to use our vital controls. The vital centers are located in this region. So in the pons, we have the area where our pneumotaxic center is located, controlling breathing, and that's going to help us transition from inhalation to exhalation, a very important part of this process. And transitioning from inhalation to exhalation is timed perfectly to the stretch of the stretch receptors in the chest, and then also in the increase in pressure in that process. So if we take a deep breath in, we've basically let our pneumotaxic center rest for a while, and then we're going to convert over into the exhalation phase. So we can have varying levels of the person's breathing in depth form if we have an injury to the pons. That should make sense since Cheyne-Stokes ventilation has changing rate and changing depth associated with that pattern, where it starts off with apnea, starts off with very shallow and slow breaths, making deeper and deeper and faster in breaths to a crescendo, and then it goes down towards apnea in the same way and happens again. That's indicative of head trauma and increasing intracranial pressure. Now let's look at the other things that are here too, because these are all associated with head injuries as well. Sleep, so lots of consciousness. Swallowing, a big part of a stroke injury often. Facial expression, part of our stroke assessment. Eye movement, part of our assessment for intoxication, hypoxia, following the 6 cardinal gazes, following the pen to the H pattern to check the working of cranial nerves. All of that stuff's originating here in the pons. Facial sensation, so another cranial nerve. Posture, bladder control, and sleep paralysis. And bladder control is a big part of head traumas. If a patient has lost continence and urinated on themselves after hitting their head, that's a significant sign. And then finally, before we exit the brain altogether, now enter in the spinal cord and the spinal column, the medulla oblongata. The medulla is where our vital centers are located. So it has a very big role in all of the normal vital signs that we would take for a patient to determine what their standard is for ABCs. Their breathing is controlled here. Their autonomic nervous system controlling cardiac, respiratory, the vomiting center, and their blood vessel constriction versus dilation is all located in the medulla's vital centers. So the vasomotor center is going to change the patient's blood pressure, and this is sometimes associated with blood pressure changes and heart rate changes in the opposite direction that we would expect for shock are associated with significant head injuries, where they'll have a very low heart rate and very high blood pressure. Often patients with head injuries will also have bouts of sometimes very forceful projectile vomiting. So you can see as the pressure develops from an epidural bleed, a subdural bleed, or intracerebral, where the brain is broken apart and started to bleed, all of that pressure, since it has nowhere else to go except the brainstem, is going to magnify here, and that's where we get our signs and symptoms associated with head injuries and increasing pressure in the brain from medical injuries and infections. All right, so there's a whole section on that, viewing the brainstem inside the app that you can check out. Okay, so we've gone now from the brainstem and we've expanded out. So now we're basically between the brainstem and the inside of the pia mater. So that area there is called the cerebrum or cerebral cortex. And this you can think of as being a portion of our anatomy that we don't actually, it's very unique to us. It's where our higher level thought, the things that are associated with human versus animal are located. Animals have blood pressures and heart rates and ventilatory rates. All that stuff happens because many animals have brainstems not too much different from our own, but most of them lack the cerebral cortex. So this is where personality and our experiences as a human being are located. We don't know how, but this is where it seems to occur. And without it, we assume that you don't have those experiences. So it's the largest part of our brain. The outer lining of it is gray matter, and the inner lining is made up of a bunch of different areas, some of it being white matter, but also we have ventricles inside the center of the brain to help regulate pressure and really create things like CNS, CSF, cerebral spinal fluid. So injuries here and illnesses here can be pretty substantial depending on which area of the brain is impacted. Again, because we'll know what parts of the brain do what, we're going to then be able to say, okay, if this is what my sign and symptom is abnormal in my patient, this might be the part of the brain that's attacked or impacted by that injury. So well, the brain's going to have high organization between neurons to create experiences, but most importantly also memories. Mental processes and memories that are done over time give rise to the person's personality, who they are, what their job is, what they describe themselves as, what they enjoy. If you've been working on fly fishing for 10 years and suddenly you have an injury to that region of your brain, then you'll lose that altogether and may not ever be able to actually learn it again, depending on the type of injury that occurs. So it's very important that we're sensitive to this area of the brain and how quickly it can start to perish after a lack of oxygen. So be able to identify those visually if presented with the picture, as well as by their description. The frontal region is located in the front of the brain, and so most of our dopamine neurons are located there. Remember, dopamine's created, as in one area, it's created is in the midbrain, in the connection to the rest of our cerebral cortex. Here's where we find a lot of our personality, our behavioral affect, the way that we present ourselves physically in relation to our senses and our emotions. Inhibition comes from this area. So patients that have had this removed in lobotomies, it was very common that this was removed in the lobotomy. Those folks then generally didn't have really any seemingly external or internal enjoyment, and their affect was flat. And it was a lot of times done in really bad medicine and torture, essentially. The parietal region basically sits between the occipital, which is the back, and the frontal lobe, obviously located in the front. So the parietal region is where our sensory and motor function is located. So different regions of our body are spread across this area of the brain. It's actually been mapped. The occipital region is the very rearmost region in the posterior. It's controlling vision and color and motion differentiation for our sight. The optic nerve makes its way to this region by passing basically through and around the midbrain. And then finally, below the parietal and in between the occipital and frontal, on the bottom portion of our brain, basically on the bottom of our skull, is the temporal region. Hearing, a lot of memory is associated with, obviously since hearing is big in memory, and spatial awareness. So remember that our inner ear has control over, or helps measure, if you will, where our body is in relation to the ground and in relation to space. So our body's awareness of where it is highly processed in the temporal region. Okay, the cerebellum is a region of the brain that we've kind of touched on a little bit. It's at the very rear of the brain, and it's connected to the midbrain, the pons, and the medulla oblongata, but very heavily, most of its body is over the pons. So remember, fine motor control originates here, and it's the second largest section of the brain to the cerebral cortex. When we're able to maintain our posture, especially when we're moving down the road, those are fine-tuned signals. They're not really big moving signals because we're trying to stay still. So we're countering our movement. Think of the back of the ambulance. If having to stand, unfortunately, puts you at a lot of risk, if having to stand while you're moving down the road. In that case, you're really using your hearing, your sight, your senses, your proprioception, and essentially the movements of the cerebellum to counteract the sensory that it's receiving as the vehicle moves. And someone can do this really effectively, especially if they can anticipate which ways we're moving from their visual processing. Now, the central brain structure is more complex than essentially just the brainstem. The central brain structure is basically made up of all of these other structures like the brainstem, the midbrain, the forebrain, the neocortex. All of those structures are definable. And then we have a few that aren't very definable. The basic ganglia is one that we've already kind of hit on, but the diencephalon is another one, and it's actually associated with that area of the brain. Like emotion, control for our ANS is in a region of this as well. The pituitary gland is controlled in this region. It's a structure around the hypothalamus. So you can really see this well in the Complete Anatomy app as you explore the central brain structures. So I've highlighted that. Now again, these aren't necessarily actual structures. They are regions sometimes. Like diencephalon is made up of a bunch of other structures that give rise to its similar traits. We can see here the diencephalon and the limbic system outlined, so they're parts of our other portions of the brain, and the structures that we have highlighted here all have specific roles. Not highlighted here at the bottom, that little P-shaped thing in front of the amygdaloid body, that's the pituitary gland, which is the master gland of our body. It controls, by communicating in a chemical way with the rest of our organs, what the brain wants to relay. So the nervous system and our chemical messenger system, the hormones, can make this work, and that's going to be connected directly to the central nervous system. An interesting gland that we'll explore quite a bit. Okay, the thalamus is a required topic for paramedics, and it's really a region that is right next to the brainstem, so works on core body functions. The hypothalamus, just underneath of it, is where our control of temperature regulation and metabolism comes about. And in the thalamic structure, which is shaped basically like a set of dumbbell, is going to relay sensory impulses to the sensory areas of our high level of brain. And there's pleasantness and unpleasantness associated with sensations, but that's driven by neurotransmitters being released in the region as well. And the hypothalamus, connected to the thalamus, just below it, is where an extension of the pituitary gland is going to originate. We'll learn later that the pituitary gland has anterior and posterior, and we'll learn exactly what hormones come from these regions. But for right now, separating anterior and posterior is important because the anterior pituitary gland is going to have an area of hormones that are released when the hypothalamus says to do so, but they don't come from the hypothalamus. They're released from the gland itself. That's different than the very few, compared to the anterior, the very few hormones released in the posterior pituitary gland, where the hormones are secreted directly from hypothalamus-related axons. So that can have direct control over our blood pressures, the temperature, and the circadian rhythm in that connection of electrical through our nervous system and chemical in the endocrine system. Okay, so all the structures are in the central brain region of the slides on complete anatomy. To wrap up the brain section of the central nervous system, let's talk about a couple brain disorders. Now, I'm just kind of hitting the highlights here. These disorders, especially the emergency disorders, are going to be covered again in other classes in the future. But we can apply what we already know to some of these things. Let's start with the CVA, the stroke. A cerebral vascular accident is going to be a irreversible disease process inside the brain, and it has two flavors we'll explore in just a moment. Both of those flavors are outlined in the Complete Anatomy app as well, and we often can't tell which one it is. So a stroke by itself generally has the same treatment, but we try to do the best we can for the one that can be reversed within parameters. We'll talk about that more a little bit later and in future courses. Let's talk about cerebral palsy. When we hear the term palsy, a lot of times that's associated with the paralysis of some portion of the body. Cerebral palsy is a condition in which the communication with the rest of our body from the brain is inhibited, specifically in our motor control and the control of voluntary muscles throughout the body. So in patients that have this, a lot of times they have paralysis of a limb, and they're not necessarily equally paralyzed on both sides of the body or through both limbs. They become spastic, and so their muscle starts breaking down because it's not working. So we end up with muscle atrophy, which is essentially going to happen in the idea you learned of, if you don't use it, you lose it. That's what we're basically talking about. And so this can also have not just the destruction of muscle tissue, but also they can have their limbs form into abnormal positions and pretty painful looking contortions as well. The big thing that can come up for paramedicine in this, aside from the actual disease and them not having motor control, so things like caring for themselves are virtually impossible. But this can eventually affect things like their control of breathing, and they can end up with paralysis of the chest and their diaphragm, and unfortunately asphyxiate, or they can have infections that come on early because they can't take deep breaths. So that's the worst case scenario a lot of times. There's certainly other things that can happen, but that can be some of the worst cases scenarios associated with cerebral palsy. Here's a picture of the patient with cerebral palsy and is able to move around. I've seen patients that can't move around. They're bedridden their entire life, so it can be progressive as well. Degenerative diseases will have a couple subclasses below them. So there's dementia, Alzheimer's disease, Huntington disease, and then HIV, which is basically associated with dementia. So we're talking about HIV-based dementia in that case. When we're talking about dementia, there's a common term that we need to associate with it in opposition. It's really easy to memorize medical terms if we know its opposite as well. So dementia is often compared to delirium. Dementia and delirium. Dementia is a degenerative disease, and delirium is not necessarily a degenerative disease. Dementia occurs probably in most cases over time, where the patient's thought process gets progressively worse and worse, and their intellectual capacity starts to become limited. Their attention span decreases, their memory changes, their personalities may change as well. They may have motor control issues in addition to it. So, it, as mentioned, as degenerative disease means that it gets worse over time, degenerates over time. Alzheimer's disease is another disease in the degenerative area, and in this case, they generally will occur to have this in their middle to late adult years, and dementia is a symptom of it. Dementia is that progressive loss of their cognitive ability. Delirium, as mentioned as the opposite, is a break with reality. Dementia happens slowly over time and is usually irreversible. Delirium usually has a sudden onset and often is reversible because of the causes associated with it. So because we have degenerative disease in the title, these types of diseases are going to have a loss of brain tissue. And so the picture here of a normal patient's CT scan, and then next to it on the right, Alzheimer's disease, you can see that it no longer has that gray, in this color blue, presentation throughout the entire region, and the edges are more defined with black areas. So the center of the brain is being basically destroyed, degenerated, and those neurons are gone, as is the grooves are getting deeper and deeper compared to the normal patient's brain. Not necessarily associated with these disorders, but of its own, seizure disorders are another disorder that are common associated with the nervous system. You're going to explore the different types, and there's lots of different types and subtypes of seizures. You'll do that partly in your EMT basic and intermediate class, but at more depth in the neurology class. Seizures in general, though, the physiology or pathophysiology of them is, remember that we say a neuron in doing its thing, whether that's a thought, whether that's a memory, whether that's sensing something or telling your body to do something. Any of those cases is depolarization, where the electricity goes over the length of the axon and communicates to another cell somewhere else. Well, the electrical activity is coordinated in most patients, like me doing this lecture, very coordinated. You studying, very coordinated. Electrical impulses are allowing you to do this. In a seizure, they have either their entire brain or regions of their brain firing all neurons, but in a non-coordinated manner. And remember, when we fire a neuron, part of us getting stuff ready for the next depolarization is consuming energy. So it can be a high consumption of glucose in the brain when the person's having a seizure, which is important that when you have a patient that's having a seizure, you absolutely have to check a blood sugar. Now, you should be checking a blood sugar in that patient for a different reason. You should have memorized already in your EMT basic knowledge, at the basic core of being a functional EMT, you should already have memorized that if a patient is unconscious, you need to check a BGL in every case. If they have altered mentation, you need to check a BGL in every case. It's so simple to do. Do it if their mentation is not 100% or 15 on the GCS score. Seizures can be caused by low blood sugar, as is a seizure not caused by low blood sugar can cause low blood sugar and make itself worse. So anytime there's altered mentation, a seizure needs to be considered and assessed for, as does a BGL assessed in a patient with altered mentation. Remember that not all seizures are going to be the flopping on the ground like a fish out of water type of seizure. Some of them are very specific parts of the brain in which their behavior external, their motor movement, isn't going to tell us enough. The disease epilepsy is, and there's lots of different forms, and it's basically a catch-all, if you will, to say that there's recurring seizures. And often it's used as a term of they don't know why there's recurring seizures. It just happens in that patient more than once. And so epileptic patients often have a very heavy medical regimen that they have to take, and it may involve medications that are trying to coordinate or deaden in some ways, slow the response of those malfunctioning neurons that are causing those discoordinated electrical impulses. Not that we do this in the field ever, but an EEG is a graphical representation of the electrical waves in the brain. Now remember, an EKG is for the heart. Now, I've already mentioned that basically the depolarization of a cardiac cell is very similar and has the same steps that we described in the nervous cell. And so an EEG is a graph representation of exactly what we saw, that depolarization caused by sodium rushing into the cell from outside and causing a positive change on the outside to go to the inside and reverse polarity. The EEG is basically measuring it just like an EKG is measuring that same process, but in the heart. Okay, back to those strokes. I felt like I could give them a little bit more knowledge, give you a little bit more discussion on strokes in general. So a stroke used to be called a CVA, and in some layman's terms, it still might be called a CVA from just old use of the term. Well, CVA is cerebral vascular accident, and it is cerebral and it is vascular, but most strokes are preventable by changes in lifestyle, medication, and other things that make it not a completely unpreventable event. An accident is an event that's completely unpreventable. So the two flavors are ischemic and hemorrhagic. We don't often know this difference in the field. There are some things that we'll come to learn a little bit later that can put us in the more likely this versus that side, but we'll never really know unless we're working on one of the cool ambulances that they have on the East Coast called mobile stroke units. So an ischemic stroke you can really equate very similarly to a heart attack. This is where a blood vessel inside the brain has been blocked by some type of plaque, very often associated with fats, and that blockage is causing the area downstream, since it's blocked, it's not receiving oxygen, it's not receiving glucose, and it's not having those waste products evacuated either. And so an ischemic stroke can cause brain damage by hypoxia. A hemorrhagic stroke, though, is an aneurysm, essentially. A part of a blood vessel has broken, and so everything downline from that is not receiving oxygen, just like the ischemic. But a big difference is that the hemorrhagic stroke is bleeding into brain tissue. The blood vessels keep blood inside the vessels for a reason. Blood, when it comes in contact with neurons, is starting to break down and destroy neurons. So the hemorrhagic patient has two major things contributing to their demise. The transient ischemic attack. Notice that the word uses ischemic and not hemorrhagic in that terminology. A transient ischemic attack is basically stroke-like symptoms that resolve within 24 hours without long-term damage. Now, when we get called to the scene, we're virtually never going to be on the scene with our patients for 24 hours, I hope. So as we're kind of thinking about this process, just keep it in the ischemic realm, because what's happening here is the blood vessels are being blocked, but they're small enough that even though they got stuck, at some point they just break off and then circulate again. Well, this is concerning. So while they have the blockage, they're going to have the signs and symptoms of the ischemic stroke. But once it breaks free, then blood returns to that area, evacuates the waste byproducts like acids and accumulation of carbon dioxide, all of that stuff accumulating and destroying tissue. It's now flushed out. And so in most cases, they have a complete reversal within that 24 hours. Well, the bad part of this is that although they benefited by it not being long-term and self-resolving, so it means that they're very much likely to have a stroke. Patients who have had transient ischemic attacks in the past, if they have signs and symptoms of a stroke, we assume it's a stroke until proven otherwise, and we'll treat them as such.